Welcome to The Explainer. Today we're taking a close look at the human heart, but I want you to completely shift how you think about it. For the next few minutes, let's not think of the heart just as a biological organ. Instead, imagine it as an incredibly complex, fascinating mechanical pump operating inside a high-pressure, dual-circuit plumbing system. You see, like any mechanical system, the engine of your heart operates on precise physics, pressures, and fluid dynamics. And when the machinery of that pump starts to wear down, we get a fascinating, albeit really dangerous, cascade of mechanical failures.
Okay, let's dive into this. Here is our roadmap for today. 1. When the pump fails. 2. The math of heartbeats. 3. Left-sided heart failure. 4. Right-sided heart failure. And finally, 5. Fixing a failing heart.
All right, Section 1, when the pump fails. We need to define the problem.
So, congestive heart failure, or CHF, this is basically the point where the heart just cannot supply enough blood to meet the body's ongoing demands. But the absolute key word you need to pay attention to here is congestive. Think about it. When a pump fails to push fluid forward, well, that fluid has to go somewhere, right? It backs up, it causes a massive physiological traffic jam, literally congestion, in the plumbing behind it. This fluid buildup is the absolute hallmark of the disease, and because it means the body's systemic needs just aren't being met, it can ultimately be fatal.
Now, this failure essentially happens in one of two ways, and honestly, it's best to just think of them as the squeeze problem and the fill problem. Systolic heart failure, that's the squeeze problem. This is when the heart's ventricles simply cannot pump or contract hard enough during systole to eject the blood. On the flip side, we have diastolic heart failure, which is the fill problem. In this case, the heart might be squeezing just fine, but the ventricles are physically unable to fill with enough blood during their resting phase, called diastole. But here's the thing, whether the pump is too weak to squeeze or too stiff to fill, the end result is exactly the same: inadequate blood flow forward and a massive traffic jam backward.
Moving right along to Section 2, the math of heartbeats, calculating output.
Let's look at a healthy pump first. Your heart needs to squeeze out a certain volume of blood every single minute, which we call cardiac output. That's just your heart rate multiplied by your stroke volume. Now, stroke volume is kind of counterintuitive. You might think a healthy heart pumps out 100% of the blood in its chamber with every beat. Well, actually scratch that, it doesn't. If a normal left ventricle holds about 110 milliliters of blood, it might only squeeze out 70 milliliters per beat. That leaves about 40 milliliters just lingering in the chamber until the next beat. The fraction of blood that actually gets ejected is called the ejection fraction. So in this healthy example, 70 divided by 110 gives us an ejection fraction of about 64%. A totally normal healthy range is usually between 50 and 70%.
Now, what's really interesting about this is how the math completely changes when that squeeze problem happens. If the ejection fraction drops to 40% or lower, we are looking at clear systolic heart failure. Think about the numbers. If the total volume is still 110 milliliters, but the weak heart can only manage to squeeze out 44 milliliters, leaving 66 milliliters lingering behind, well, the pump is failing. It's barely moving the fluid forward. But remember, we also talked about diastolic failure, the fill problem. In that scenario, the total volume of the chamber drops because it can't fill properly in the first place. So even if the math says the ejection fraction looks like a normal 64%, the actual physical volume of blood being pumped out is still dangerously low.
So how does the heart try to naturally fix this low output? It uses something incredible called the Frank-Starling mechanism. This quote really hits the nail on the head. When you load up the ventricle with a larger volume of blood right before it contracts, a volume we call preload, it stretches the cardiac muscle. And just like pulling back a rubber band, stretching that muscle makes it snap back and contract with way more force. The heart is literally actively trying to stretch itself out so it can squeeze harder and compensate for the failing system.
But over time, the heart's desperate attempts to fix itself under all this high pressure actually end up causing more damage. Look at these two pathways. Say a patient has long-standing high blood pressure. The left ventricle has to work so incredibly hard that it bulks up. The muscles grow in a process called left ventricle hypertrophy. But because this growth happens inward, concentric hypertrophy, that thick muscle crowds the inside of the chamber. There's literally less room for blood, causing that diastolic filling dysfunction. On the other hand, in dilated cardiomyopathy, the heart relies on that rubber band effect by constantly dilating the chamber to increase preload. It stretches and stretches to fill with more blood, but eventually, the walls get dangerously thin and weak, leading to systolic dysfunction. Either way, the pump's physical architecture becomes permanently ruined.
Okay, Section 3, left-sided heart failure, the pulmonary backup.
This sequence illustrates a truly terrifying anatomical domino effect. Step 1. The left ventricle fails to pump adequately. This is often because of ischemic heart disease or an old heart attack that left dead scar tissue behind. Step 2. Because the blood isn't moving forward, it starts to back up into the pulmonary veins. Step 3. This massive backup increases pressure so much that fluid is physically forced right out of the blood vessels and into the interstitial space of the lungs. We call this pulmonary edema. The lungs literally become congested with fluid. And step 4. The pressure can get so intensely high that capillaries in the lungs actually rupture. Red blood cells leak into the alveoli, and immune cells called macrophages rush in to eat them up. Because of the iron in that blood, these cells turn a brownish color and are clinically referred to as hemosiderin-laden macrophages. But honestly, they're more commonly and grimly known simply as heart failure cells.
As you can imagine, having lungs full of fluid and ruptured capillaries translates into some really severe real-world symptoms. Patients experience dyspnea, which is intense trouble breathing. Why? Because that thick layer of fluid acts as a physical barrier. It makes it incredibly hard for oxygen and carbon dioxide to exchange in the lungs. They also experience orthopnea, which is difficulty breathing when lying flat. And the mechanics of this make total sense. When you lie flat, gravity allows venous blood from your legs and gut to flow back to the heart much easier. This completely overwhelms the already congested pulmonary system. If a doctor listens to the lungs, they'll often hear crackles or rails. That's the sound of the patient trying to breathe through all this excess fluid. Section 4. Right-sided heart failure, systemic congestion.
So it's actually very common for left-sided failure to eventually cause biventricular failure, where both sides of the pump break down. But you can also have isolated right-sided failure, and this shows us exactly how that happens. Imagine a patient with a chronic lung disease that makes oxygen exchange really difficult. This causes hypoxia, or low oxygen. In response to that, the pulmonary arterioles constrict. This constriction causes pulmonary blood pressure to absolutely spike. Suddenly, the right ventricle has to pump against massive resistance. Over time, just like the left side, it hypertrophies, it thickens, it becomes ischemic, and eventually it fails. When a lung disease directly causes right-sided heart failure like this, it's medically known as cor pulmono.
So the crucial point to take away here is understanding exactly where the fluid backs up. Let's look at this breakdown. When the left side fails, the traffic jam goes backward into the lungs, giving us that pulmonary edema. But when the right side fails, it backs up into the entire systemic body. You'll see jugular venous distension, literally a visibly bulging vein in the neck. The fluid backs up into the organs, causing the liver and spleen to enlarge painfully, which is a condition called hepatosplenomegaly. Fluid can even leak into the peritoneal space in the belly, called ascites. And finally, gravity pulls all this excess interstitial fluid down. This causes pitting edema in the legs when a person is standing, or in the lower back sacrum when they're lying down. You can physically press your finger into the swollen tissue and it leaves a visible pit.
Finally, Section 5, Fixing a Failing Heart, Medical Interventions.
So how do we fix it? The treatments for heart failure escalate depending on just how severe the mechanical breakdown is. For both right and left-sided failure, doctors almost always start with medications. ACE inhibitors are used to dilate the blood vessels, effectively widening the pipes to reduce resistance. Diuretics are prescribed to force the body to excrete fluid, which reduces that overall congestive traffic jam. But as the heart walls stretch or thicken, the cells get irritated, and that leads to arrhythmias, where the ventricles fall completely out of sync. To fix this, a CRT pacemaker can be implanted to perfectly sync up the contractions again. If the pump is truly failing, hardware like ventricular assist devices, or VADs, can be surgically implanted to literally, mechanically pump the blood for the heart. And finally, in end-stage situations where the biological machine is completely unsalvageable, the only option left is a full heart transplant.
We have covered a lot of ground today, tracing the exact math, mechanics, and domino effects of a failing cardiovascular pump. The human heart is, without a doubt, a true mechanical marvel. It beats millions of times over a lifespan without a single break. But it operates on incredibly delicate physics. So, I want to leave you with this thought to consider. Given how precisely tuned the heart's pumping and filling cycles are, and how absolutely devastating it is when that fluid starts to back up, how can we better preserve the machinery of our own internal plumbing before the pressure gets too high? Thank you so much for exploring this fascinating topic with me. Keep learning, and I'll catch you on the next explainer.